everybody. Thank you for being here. I'm Marjan Askar. I will be moderating the oral abstracts for pediatrics. And we have John Dickens, who's our medical student ambassador. Very happy to have him. He's graciously offered to monitor the chat for us. And I think that just to make sure all the presenters are there and we have enough time, we'll wait until the end, and then John will sort of let us know what the questions are, and we'll wait for the replies from the presenters. So without further ado, I'll give it over to the presenters and mute myself. Happy to be here.
Just before I share my screen, John, just so you know, it looks like there are a couple people in the other in the Juno thing. I'm not sure if everybody's made their way over or if they know how to do that.
Okay, I will direct them. Thank you.
Let me just share my screen here. I'm
assuming John, you want to come in or?
Say that
I'll hop over there, and you guys can get started here, and I'll hop over there.
Perfect. Okay, let's go ahead and start.
All right. Do you guys see my slides? Great.
Yes, we do.
All right, so my name is Keith Kleinman. I'm one of the second-year Pediatric Emergency Medicine Fellows at Johns Hopkins University School of Medicine. And I'm pretty excited to talk to you guys today about my research, digital versus traditional otoscopy, assessing trainee supervisor agreement. I have no conflicts of interest or disclosures and will not be discussing any off-label use of anything. So why are we talking about this? So as everybody knows, ear pain is a common reason for kids to present to the emergency department or to present to urgent cares and associated conditions with fever and things along those lines. The other thing we also know is that otitis media is often misdiagnosed, overdiagnosed, and antibiotics are often prescribed when they probably didn't need to be. And I think that's a multifactorial problem that we all can hypothesize as to why that would be the case. But I think one of the pieces that really leads to that is the otoscopic exam is difficult, and it's difficult for quite a few reasons. But one of the main ones, I think, is that it's difficult to learn when you are not able to simultaneously look at the same thing that the person who is trying to teach you is able to see. And that's a real barrier to the current education that we have. But if you use a digital otoscope that projects an image onto some kind of device, then you are able to then see the view simultaneously. And so what we wanted to assess is whether the digital otoscope would improve the inter-rater agreement of ear exams between trainees and supervisors. Secondarily, we also wanted to evaluate whether if we used a digital otoscope, are we able to then decrease the total number of times a child has to have their ear looked in? Because if you can record a video, then the supervisor is able to look at that. And so that could potentially decrease the length of stay in the emergency department, and it also would decrease the number of times that you have to, hold down the bucking child and look in their ears, which we all have had the pleasure of doing. Other things that we wanted to look at is there was a difference in confidence between the digital and traditional otoscopes, and whether or not there was a difference in antibiotic prescription rates. So to give you a quick example of, or a view of what we were doing, the devices that we used in this study are both shown here. So on the left, you have the traditional Welch-Allen handheld otoscope that I'm sure we've all used. But on the right, you have the CellScope Oto, which is actually no longer in production, but it is a cell phone-based digital otoscope. It's an iPhone 7 peripheral attachment that uses the light source and camera of the iPhone 7 in order to magnify and project an image, and then also has a HIPAA-compliant, secure storage service that allows you to record those videos. And so what we did is we designed a randomized controlled clinical trial that was evaluating the two devices. One of the complications in this study design, or what made it a little more difficult, was the fact that when trainees rotate through the emergency department, they often do it in either sporadic or very shift work-like fashion. And so it's hard to capture the same trainee in any given window multiple times, or especially if you only look at a very short period of time. And so what we did to control for that is we used block randomization, where we did 1 week increments where you were able to use the digital otoscope, and then another week where you weren't. And they were randomized essentially as to whether it was CellScope week or not. When the CellScope wasn't a CellScope week, they were locked in a box and you couldn't use it. When it was a CellScope week, we encouraged people to use it during their clinical shifts as they saw fit. We did this in an academic, urban pediatric emergency department and acute care clinic. We included any child that needed an ear exam, and that was determined by either the trainee or supervisor. There were no exclusion criteria. The participants of the study, we used residents, medical students, PA students, and NP students, all the people who typically rotate through our emergency department. We had supervisors that were attendings from pediatric emergency medicine, general academic pediatrics, and also fellows from both of those divisions as well. And in order to calculate our sample size, we had to factor in the non-independence of the 2 ear exams. And so essentially on any person, you're going to look in both ears, and one finding might affect the other side, depending on how you interpret something. And so to control for that, we used the variance inflation factor with a correlation of 0.3. And we found that in order to detect a 15% difference in accuracy, we needed 344 ears, or 172 children. What really sets us apart from prior studies that have looked at different things, similar things like this, is the fact that we used a validated scale in order to assess the otoscopic findings. So this was developed by Lundberg et al. In 2013, and it's called the Omgrade scale. And as you can see, as you move up from 0, which is a normal exam, to up to 5, becoming more and more abnormal, it allowed us to report our findings in a more uniform manner than any study had done previously. So the way the study worked is essentially the resident or trainee medical student, PA student, would go into the room, they would take their history, they would do their exam, and when it came time to look in the ears, depending on if it was a cell scope or a traditional week, they would use whatever device that they were assigned to use. They would then come out of the room, report their findings on this card, but importantly, they weren't allowed to tell the attending, they weren't allowed to precept before they did it, and they weren't allowed to show the attending or supervising fellow what they reported on this card. And then the fellow would then, or attending would then fill out the preceptor side of it. And then we would take the data, look at the differences between the supervisor and the trainee. In order to incentivize this, because we had a rather large sample size, we used $25 gift cards that were raffled off each month, one for the preceptors and one for the trainees. And it actually worked really well in order to get people to fill out a survey, as each survey counted as a ticket for entry into the raffle. So our findings were, we got 197 children, or 394 years. We conducted this study from July of 2019 until February of 2020. We just snuck in before Hopkins shut down all of the research because of COVID. We had 88 unique trainees, 23 supervisors. About 85% of the people that were considered a trainee were residents, 60% of which were pediatric residents, and the other 40% were either general emergency medicine residents or family medicine residents that rotate in our space. We had a very even distribution of PGY year, and then the distribution of age of children really makes sense based on the age of children that you would typically be looking in years anyways. And then we had a good randomization between the devices with 98 and 99 total samples. So our outcomes are here, and this is our primary outcome. And so what we showed was there was an 11.2% increase in accuracy between the digital and traditional otoscope. So just using the digital otoscope took you from about 64% of the time agreeing with the attending to 75% of the time agreeing with the attending. We also wanted to look at the inter-rater agreement using Fleiss Kappa, where we were able to show an increase in the agreement from 0.4 to 0.69. And it seems like this could be redundant, but the reason we did this is really that the accuracy and agreement are looking at different things. So the accuracy piece is looking at a binary yes, no. Did the attending and the trainee, did they see the same thing, and did they report the same thing? And so on the Omgrade scale, the trainee says 0, the attending says 0, that's considered accurate. If the trainee says 0 and the attending says 1, that's inaccurate. Now, the thing that doesn't take into account is I'm more concerned if a trainee says 0 and the attending says 5 than if the attending says 0 and the attending says 1. That variation in the sample, I think, is important. And that's what the Fleiss Kappa, looking at the level of agreement, really was able to show us, is that when using a digital otoscope, the attending and trainee were more close together in their level of agreement there. And so both the accuracy and agreement were statistically significant improved. And I think that together, that is a pretty powerful finding. Secondarily, we were able to show that there were significantly fewer repeat supervisor exams. So when using a traditional otoscope, 98% of the included subjects had their ears looked at a second time by an attending or fellow to confirm the trainee exam. However, when a traditional otoscope, or a cell scope oto was used, only about 30% of the time did that occur. And so that was a pretty substantial reduction that really could lead to improved care for the child if they don't have to be held down twice, and then also potentially like I said, improve length of stay. There was no difference in confidence that was seen between the two. And I actually think that there's a lot of ways you can interpret this. And one of the ways that I think, like on the more optimistic side of interpreting this, is we didn't do that much to train people how to use the device. We showed them a video, and then in person, we showed them how to use it 1 or maybe 2 times. And then they went off and used it. And if they felt just as confident, I think that that shows that these devices have relatively easy uptake and are fairly easy to use in the current environments. And then the last thing is that we showed that we were not able to find a difference in the antibiotic prescription rate. However, there does seem to be a trend in that direction, but we're really not powered to answer that. I think this finding, what I like about this is that this is the target, I think, of future studies right here, is if someone could get a larger sample than we got of people that actually had antibiotics prescribed, then this, I think, would be a really interesting finding to see if the trend that we begin to show is actually there. So ultimately, in conclusion, the utilization of a digital otoscope increases the agreement between the trainee and the supervisor. It decreases the total number of examinations performed. And we think that when used in an academic environment, a digital otoscope is an efficient and effective teaching tool that probably has a role in clinical practice. I just wanted to thank my mentors, Dr. Canaris, Dr. Solomon, and Dr. Kim, and also the Johns Hopkins Children's Center's Innovation Grant for funding this project. And with that, I'd be more than happy to take any questions from anybody who may have them.
This is Jim Holmes. Just one question. How much does one of these things cost?
That's a really good question. So like the CellSoap Oto no longer is in production. The company was bought, we think, for their IP, and they're not actually being produced. But when we bought them, I believe they were about $150 to $200 for the peripheral attachment. And then there's the cost of the phone. But now we bought them about 4 years ago, I believe, if I remember correctly. Now you can go on Amazon and buy something very similar for about 30 to 50 bucks. And so I think that the cost has come down quite a bit and is going to probably continue to come down.
Hey guys, this is Mo from the program committee. Just wanted to let Keith know that the pediatric interest group has voted your abstract as the top abstract in a fellow category. So you're going to get a lot of recognition for that. So congratulations.
Thank you. That's very exciting. Thank you very much. I guess I can stop sharing my screen.
Yeah, thank you so much. Who do we have next on our presenter list?
I think that's me, Kendall
Okay.
Burdick.
Oh, hi.
Hi.
All
I'll
right.
share my screen.
Thank you.
All right. So I'm Kendall Burdick. I'm a current third-year medical student at the University of Massachusetts. I'll be presenting what 911 gets you, who has appropriate access to a pediatric trauma center, on behalf of my co-authors listed here. I have no disclosures, but this work was funded by the EMF SAEM Medical Student Research Grant that I was lucky enough to receive for this coming year. So why do pediatric trauma center access important? Trauma is the leading cause of death for children who are greater than a year old, but children are not little adults. So pediatric traumas are the most appropriate centers for children to receive care in, as opposed to a general trauma center. Therefore, access should be equitable by geography, race, and ethnicity. So how can we measure pediatric trauma access? In this study, we define access as geographic access within the golden hour drive time. The golden hour is the thought that pre-hospital transport that exceeds 60 minutes has worse outcomes for pediatric trauma victims. However, it's important to address that access to healthcare is multifactorial. So socioeconomic status, insurance status are all very important factors that go into whether or not access to healthcare is received. However, at the minimum, the ability to reach a facility within reasonable time and distance is essential for pediatric trauma victims to receive the appropriate care for themselves. So our analysis was using geographic information systems on ArcGIS, and we determined golden hour coverage area for all pediatric trauma centers in the United States. We got pediatric trauma center locations from the American Trauma Society's Trauma Information Exchange Program, which included all American College of Surgeon verified trauma centers in the United States. We then did a demographic analysis of who does and does not have access to a pediatric trauma center. For that, we again used ArcGIS by Esri, the 2020 US population data estimates at the block group level. We used ages 18 years or 19 years and younger, excuse me, and the race and ethnicity groups listed here, which are correlated with the census groups. So this is what we found. What you're looking at here is a map of the United States, and you see the golden hour coverage areas for every pediatric trauma center. So we see pretty good coverage in the Midwest and East Coast, and then we see sparse coverage in the West, as well as in Alaska and Hawaii. So who has access? It's a good place to start. So we had 157 ACS verified pediatric trauma centers in 44 states, and you can see listed by level below. And so overall, at the population level, 68.6% of the pediatric population does have access to a trauma center within a 60-minute ground transport time, which is great. These are children who can receive appropriate care within the literature-supported travel time. However, when we look at who doesn't have access, these numbers are concerning. So you see 31.4% of the total pediatric population in the United States does not have access to a pediatric trauma center within 60-minute drive time. When we look at the racial and ethnic groups, we see substantial inequities and disparities. We see a great range from 13% of the Asian population not having access to upwards of 60.4% of the American Indian Alaskan Native population not having access. Just for a more visual representation of this inequity, we see a significant population of 30.1% of the whole pediatric population not having access, and then substantial variety in racial and ethnic access levels. We broke this down by state level as well. And so what you're seeing here is the percentage of pediatric population who does not have access to a pediatric trauma center. We see six states with 100% of their population not being able to access pediatric trauma center within 60-minute drive time. And then great variety ranging from 100% to 0% in DC. So in conclusion, over 25 million children cannot reach an ACS verified pediatric trauma center within the golden hour drive time limit. We see substantial disparities by geography and inequities by race and ethnicity. We see overall sparse coverage and access in the Western United States. We see children in 6 states not having any pediatric trauma center access by drive time. And then nearly 2/3 of the American Indian Alaskan Native children having no access. Our next steps are to look at access in addition to helicopter access, which is a very important consideration specifically for the Western United States, which will be using the ADAMS database. We'll also look at the relationship of where traumas actually occur versus just where the population lives. And we'll be using the NEMSIS database for that analysis. And then we'll look specifically at pediatric trauma fatalities relative to pediatric trauma center coverage, which we'll use the CDC Preventive's compressed mortality file for. So at this point, I welcome any questions, and I thank you again for this opportunity to speak and share my research. Thank you.
That was fascinating. I have a question. Kendall, would you please put your email and the best contact address on the chat, because I would like to reach out and discuss some collaboration stuff. And a lot of times this comes out of these meetings, and it's phenomenal to work with people like yourself so early in your career that's doing such amazing work. Right?
Absolutely. Thank you. Yes, I just put it in the chat.
I appreciate that.
Anyone,
Yep.
please reach out with questions as well.
Thank you. Okay. That was excellent. Let's go ahead and move on if there are no other further questions.
I have a question, if it's okay.
Sure.
Kendall, very nice. I was wondering if those states that don't have, that basically it's 100%, essentially must not have a pediatric certified trauma center. Do those states have trauma centers that essentially function as a pediatric trauma center, even though they are not certified?
Absolutely. Great question, Dr. Holmes. Let me pull up a supplemental slide. So we use the strict definition of ACS verified centers. Here you can see that some states have their own verification process, and we've done the coverage area in like this kind of a UT orange color, as well as some centers are self-designated as trauma centers, and we added those in blue. So when you do incorporate those centers, we see some expanded access, but there are plus and minuses of having the verification and of course, barriers and processes in order to get the verification. So we're doing a sensitivity analysis to see the impact of this coverage, but as you can see visually, it's not going to be an overwhelming substantial contribution. Thank you for that question.
Yeah, it looks like you'll bring in some Louisiana trauma, but
Exactly.
the other states that have 100% miss doesn't look like it's going to impact those states at all.
Right, not by drive time. However, with air access, we suspect to see expanded coverage in those states. Thank you.
Kendall, also sounds like, the response time is another issue, obviously, how long it takes for them to get there. And the other thing is that since you can't change the golden hour, which is what patients' kind of outcome will depend on, you can make different golden hours for different states. But are you guys thinking that we should probably think twice about the discouragement of non-EMS transports in areas where EMS transport is prolonged, or should that not be considered an option?
So I heard two questions in there. First being the issue of ground transport time to arrival and on-scene time, which I'll put up is a consideration that we're adding in future analyses. It's my weekend plans. And but your second question is interesting about advising for EMS transport. I think if I were to put a priority on implications of this research in terms of policy, it would be we need more trauma centers. We can't change the transport, but we could just add more trauma centers. Of course, that is a 5-year plan, 10-year plan. So increased training, increased preparedness to centers that may receive these traumas that are not verified or self-designated are some small steps to get closer to substantial and appropriate coverage and treatment.
Also, again, Mo, just wanted to let everybody know that Kendall got our Pediatric Emergency Medicine Interest Group top abstract in the medical student/resident category. So congratulations to you as well.
Thank you so much. Thank you.
That was awesome. Yes, well deserved.
Thank you. I appreciate it. It was a huge honor. And I do have to go back to my clerkships. I got lucky to have a minute to step out, but please, anyone email me any questions. I'll be happy to answer them by email.
The wonderful life of a medical student.
Oh yeah, gotta deliver some babies. All right, take care.
Thank you. Okay, who's coming up next?
I think that it's me. Hi, I'm Katie. I believe I'm next, so I can go ahead and share my screen.
Okay.
All right, so like I said, I'm Katie Jerzewski. I'm from Northwell's Cohen Children's Medical Center in New Hyde Park, New York. And our project is What's the Risk? Assessing Bacteremia in Febrile Pediatric Oncology Patients with Viral Infections. My co-authors and I have no disclosures. Pediatric oncology patients are significantly more susceptible to infections, including serious bacterial infections, or SBI. This is secondary to a multifactorial breakdown of their natural layers of protection against disease. Patients not only receive myelosuppressive chemotherapies and have immune dysfunction related to impaired phagocytosis, but they also have frequently accessed implanted central lines and suffer from side effects such as mucositis and typhlitis. In the literature, variable bloodstream infection rates between 6 to 20% have been reported, highlighting this ongoing risk. These infections are a major cause of morbidity and mortality in the pediatric oncology population, accounting for the majority of deaths in pediatric oncology patients. Because of this, many practices have long been in place to protect from and reduce the consequences of these infections. At our tertiary care, university-affiliated suburban institution, it is routine practice for all pediatric oncology patients to present to either the oncology clinic or emergency department when they have a fever. These patients have a blood culture drawn and empiric intravenous antibiotics initiated. Depending on the patient's clinical status and/or absolute neutrophil count, or ANC, they will then either be admitted or discharged home to receive follow-up in 24 hours pending their blood culture results. This practice allows the medical team to determine disposition with the risk of bacteremia fully evaluated. Notably, though, studies have shown that a bacterial etiology of pediatric oncology patients' fevers is only actually found about a fraction of the time. And when patients are blood culture negative, they commonly have an identifiable respiratory viral infection. At our hospital, to further evaluate our patient's fever source and help with admission cohorting, a respiratory viral panel, or RVP, is also obtained on each febrile oncology patient. The RVP is an amplified nucleic acid test obtained by nasopharyngeal swab that uses polymerase chain reaction for detection and identification of several respiratory viruses and bacteria. Within a few hours of collection, results of the following pathogens are reported. If the RVP shows an infection that has an available treatment, it is provided. Otherwise, knowing the virus diagnosis does not currently change the antibiotic regimen or disposition planning for these patients. In this study, we aim to determine the risk of bacteremia in febrile pediatric oncology patients with an identified respiratory viral infection compared to those without. We performed an observational cohort study from July 2019 through August 2020 of pediatric oncology patients who presented with a chief complaint of fever to either the emergency department or outpatient oncology clinic. Weekly review allowed us to identify reasons for admissions and prolonged hospitalizations in real time, discussing every case with both the emergency and oncology teams. We included patients up to 21 years old with a known oncological diagnosis who presented with a reported or documented fever of 100.4 degrees or higher. We excluded patients who recently received any therapeutic antibiotics via any route of administration within 48 hours prior to presentation. We also excluded patients who represented within 7 days to avoid persistently positive results from prior infections. Results were analyzed using logistic regression in the context of the generalized linear mix model in order to accommodate multiple visits by the same patient. We reviewed a total of 190 visits from 111 patients. The mean age was 8.5 years. 85% of patients presented to the emergency department and the other 15% to oncology clinic. 94% had central venous access. The majority of visits were those of leukemia patients, but we also had visits from patients with solid tumors, lymphomas, and brain tumors. The overall estimated probability of bacteremia was 5.1%, and the overall adjusted rate of a positive RVP was 56.3%. Table 1 reviews the characteristics of our patient population. It compares those with an identified respiratory viral pathogen, or RVP positive, in column 2, compared to those without, or RVP negative in column 3. We found no statistical difference in the rate of bacteremia for RVP positive compared to RVP negative patients. Expectedly, RVP positive patients were significantly more likely to present with URI symptoms. They were also significantly less likely to be hospitalized or to receive antibiotics for longer than 48 hours. For these visits, there was also no statistical difference in several other categories: age, presentation site, mean white blood cell count, number of visits with severe neutropenia, or hospital length of stay. Figure 2 shows the identified respiratory pathogens during the study period. Overall, the majority of visits with a positive RVP were positive for rhinoenterovirus. Of the 3 patients with bacteremia that tested positive on RVP, 2 resulted for adenovirus and 1 for rhinoenterovirus. More than 70% of visits occurred before the COVID-19 pandemic. Only 54 visits included testing for SARS-CoV-2. 3 of those were positive. All 3 of these positive visits presented to the emergency department, and none of them had bacteremia. SBI pose a serious threat to the safety of pediatric oncology patients. Therefore, anytime this susceptible population becomes febrile, our institution prioritizes broad testing and IV antibiotic coverage. During the study period, the rate of bacteremia was 5.1%. So while practices are in place to reduce the risk of SBI, and while patients with identified respiratory infections are less likely to be hospitalized or receive extended antibiotic courses, all pediatric oncology patients still remain at significant risk for bacteremia. This highlights the continued necessity of carefully screening these patients for serious bacterial infections. Thank you so much for your time. I'm happy to take any questions you might have.
I wanted to ask a question if I could.
Yes.
I wanted to ask you, so in basically the scope of this study, the practice of oncology patients that are coming in with fever, the practice of getting a CBC and starting antibiotics as soon as possible, it's supported. Am I correct to assume that?
Yes, at our institution, every febrile oncology patient comes in for blood work and initiation of antibiotics.
Mm-hmm. Yeah. There's some centers that are sort of getting away from that. And so this is very interesting to me to hear this. Thank you.
Yeah, thank you so much.
Sure. Any other questions? Okay, let's go ahead and move on.
Okay, hi everyone. I think I'm next up. I'm gonna start my screen. Bear with me, I'm not the best with this. Okay, can everyone see my screen?
Yes.
Great. Okay, so I'm Mary Haywood. I'm one of the 3rd-year pediatric residents at Phoenix Children's Hospital. I'm here to talk to you guys today about my study with the utilization of Sphenopalatine ganglion block in our pediatric ED headache patients. I have no conflicts of interest or financial disclosures related to this presentation. Just to give you guys a little bit of background, acute headaches are one of the most common presenting symptoms in the pediatric ED. In one review by Bloom et al., 58% of children have had a headache in the last year. 35% of those kids present to the ED per year, and then 5.1% of those are hospitalized per year. And that's compared to 17% of the general population presenting to the ED and 1.7% being hospitalized per year of the general population. So currently, for our acute headaches in the pediatric ED setting, our mainstay of treatment is IV medications, and these often have suboptimal effectiveness and some significant side effects. Currently in Phoenix Children's, the first line IV therapies are ketorolac, compazine, Benadryl, and IV hydration in the form of an NS bolus. So recently, the Sphenopalatine ganglion block has been studied in the adult population and has been shown to be a safe and effective treatment in their acute headaches, excuse me. And recently there's been some preliminary data showing that there's similar safety and efficacy within the pediatric population. And just kind of back up a step, the the Sphenopalatine ganglion block impedes the Sphenopalatine ganglion, which is a bundle of parasympathetic nerve fibers that connects to the trigeminal vascular system, which is thought to play a major role in headache severity. So when we initially looked into this, we all thought this was going to be a treatment that was probably not available in the ED. We thought it required a needle. We thought it required image guidance. And we found out that it is actually a very easy procedure to do and lends itself well to the ED setting. So really all you need are some Q-tips, viscous lidocaine, a syringe, filter needle, lidocaine, and a spheno catheter. And our hospital uses Sphenocath, but that is definitely not the only brand available, just the one that our hospital picked. Sorry, guys. Okay. So how exactly do we do this Sphenopalatine ganglion block? So initially, we dip our Q-tips in the 1% viscous lidocaine, and we have the patient lie supine with their head in extension. We place a Q-tip in each nostril of the patient. We have them lay there for 30 minutes. This is simply to make the insertion of the catheter a little bit more comfortable for the patient. It's not actually helpful for the block itself. After that 30 minutes, we go in with the spheno catheter. We attach the 3 milliliter syringe filled with 2 mLs of 1% lidocaine. And we insert that into one of the nostrils of the patient and slowly infuse 1% lidocaine, 1 ml each side, and obviously repeat on the other side. And we have them lay supine with their head in extension for 30 minutes afterward. And one of the neurologists who did the study with me, Dr. Rastogi, was kind enough to videotape how exactly we use the spheno catheter. So I'm going to play that for you really quickly. Oh, yeah, thank you for letting me know. Sorry, didn't know the audio wouldn't play for you guys. Basically, what she's saying is she is inserting the spheno catheter into his nostril. You have the gray part of the catheter extended out. There's a flexible purple tip on the end of it when it's retracted that you want to put into the gray housing. And then once you are in the nostril, so you insert the spheno catheter into the nostril along the septum until you feel resistance, and then you pull the gray part of the catheter back, and slowly that extends the purple flexible tip down, and you slowly infuse the lidocaine and repeat on the other side. And that pretty much approximates the Sphenopalatine ganglion, and you can see that a little bit better here in this photo. This is the purple flexible tip I was talking to you about. And as you slowly infuse, it should hit the Sphenopalatine ganglion. So exclusion criteria for this block is known lidocaine allergy, unclear nasal anatomy, a bleeding disorder, a known non-responder to SPG block, and any underlying headache pathology like a tumor, mass, hydrocephalus, VP shunt malfunction. Once you've pretty much ruled those out though, or if you've ruled them in and they still have headache and it's appropriate, you could still use this though in those clinical settings if you need headache treatment. Some risks associated with this procedure are allergy to the lidocaine itself. You get some numbness of the oropharynx and you can get a foul taste in the back of your mouth. So as there's not a lot of research in the pediatric population for the SPG block, the primary goal of our study was to look at the safety and efficacy of this block in reducing migraine and headache severity in pediatric patients that presented to the ED. Our secondary goals were to compare the length of stay in the ED, hospital admission rates, and ED readmission rates within 48 hours of initial presentation between the SPG block and first-line IV medications. So we did this, obviously a single institution study, retrospective chart review. We looked at dates February of 2019 through February of 2020. We looked at patients 17 to 18 years of age that came into the emergency department with a chief complaint of headache and no other underlying pathology. So our first step is we offered them the SPG block as first line. If they chose to do that, we did the block, and if it reduced their headache, we either discharged them, or if it did not reduce their headache, we put them back to our IV medications and went through each step on that side. So our first step, again, as I said before, is ketorolac, compazine, Benadryl, and a normal saline bolus. If that does not resolve their headache, they go on to step 2, which is valproic acid. If that does not relieve the headache, step 3, which is mag sulfate and another NS bolus. And if that does not relieve it, they get admitted. And obviously, if any of these steps relieve their headache, then they get discharged. So with each patient that met our criteria, we got a pre-treatment score using the VAS scoring system. And then we did a score after each intervention. So if they got step 1, we'll start score before and after, etc. Then we compared the pre and post VAS scores, ED length of stay, hospital readmissions or hospital admissions, and 48-hour ED readmission rates between SPG block and the first line IV medications. So 345 study subjects met our inclusion criteria. 31 subjects received the SPG block, with 50% of those only needing the SPG block and did not need to be converted to step 1 IV therapies. And that's compared to 60% of the IV medications only needing step 1. Of note, there's some discrepancy in the numbers because we went back before we even started offering the SPG block to get some baseline data. So after reviewing our data, we found that the SPG block has similar efficacy to our step 1 IV medications, with an average score reduction of 6.8 points for SPG and 6.79 points for our IV medications. We also found that there was a shorter ED length of stay for those that got SPG block only compared to IV medication. So it was not statistically significant. It was still pretty interesting to see. There was no significant difference between SPG block and IV medications, however, for hospital admission rates and ED readmission rates. And there were no negative side effects reported. One thing to note for this ED length of stay is we think it would actually be more significant now, meaning the SPG block patients would be in our ED for a shorter period of time than just 52 minutes shorter with our current data. Because initially we weren't able to get any of our medications within Omnicell. We had to wait for pharmacy to bring them to bedside. But now we're able to get these medications within 10 minutes of the provider seeing the patient. So limitations of our study, I kind of alluded to before, are small sample size for SPG block. There's also some selection bias with retrospective chart review, the subjective nature of the VAS pain score, and again, as I said, the initial difficulty with medication availability in Omnicell. Some conclusions of our study is that the SPG block is safe and effective treatment for our pediatric patients within our ED setting. There's no difference though in hospital admissions or ED readmission rates between the two therapies. Some advantages though, the SPG block is a shorter ED length of stay, there's no IV required, and there's no waiting on medication infusion times. And these are my references. Move on to any questions if anyone has any.
Okay, so this is Mo. Thank you very much for this awesome presentation. I work at Harbor UCLA, which means I have the most awesome emergency medicine residents who would love procedures. And this is one of the things that they all want to do. Like, can I do it? Can I do it? And so my question for you is looking at this from the, like trying to set this up, scalability, and then doing a prospective. My concern is that there's going to be a small subgroup of patients for whom this is applicable. I'm very nervous when a smaller child comes with headache, for example. I don't want to entertain that there. I'm also thinking about not to just stop the headache at any expense. There are some people whose headache needs further evaluation. It's not just a matter of coming to the ED, getting your headache fixed and going home and not missing something, for example. What are you finding from your chart review that wasn't common for what group of patients moving forward can be suitable for this? Again, age being one thing, type of headache, history. What do you find in that model? What would be a good thing?
Yeah, so the age, obviously, we chose 7 and above, more for the VAS scoring. We thought anyone younger really weren't going to be able to tell us how bad their headache was. Also, obviously, there are some patients that, yes, you do need to work up further and they are not going to be good candidates for this procedure, at least initially. I think if you work up their headache and you don't find anything concerning, then they should definitely get this procedure.
Yeah,
otherwise,
about like 7, 7. If it's somebody is 13, I'm okay with that, because migraine and some of those diagnoses start being prevalent there. But I'm a little bit hesitant to kind of take an undifferentiated 7-year-old and say, well, I couldn't find anything, so let me just do. So that's what. And have any kind of, in your retrospective chart, did you come up with anything, especially in a younger age group, that was concerning?
Yeah, most of our patients actually were more in the preteen, adolescent years. We had very few patients that were under 11 years of age. And then the patients that did respond really well to the SPG block, some of them were kids that did not have chronic migraine issues. They were not on medications, outpatient, they were not followed by neurology. However, there were a couple of our chronic migraine kids that responded very well to this SPG block and actually were out of the ED for 6+ months after receiving it, when they had been frequent flyers of the ED previously. However, that was not the case for all of our chronic migraineurs, as I'm sure you can imagine. So I don't think we have a great conclusion on whether or not this is going to be better for those kids that are first-time headaches, or if this is going to be good for the chronic migraine kids. I think that's something that will probably need to be studied a little bit more. But I don't think the chronic kids, sorry.
Go ahead, sorry, go ahead.
I was just gonna say, I don't think that having a chronic kid precludes them from trying this if they've never had it before. I think it would be a good thing to try at least.
Yeah, I think the chronic ones with headaches that have been migraine diagnosed already and have been not super successful with the previous method, this might be a good way to decrease their ED length of stay, reduce some of those admissions. The known entity ones I'm more comfortable with.
Sure.
But the ones who are, we're just trying to solve their headache, that's the part that I was asking. The other thing I was going to say is that we do this sometimes, and if you don't have this fancy devices that you showed, sometimes there's long Q-tips. You can impregnate those in lidocaine and just put them on in the nose, and that works well too. So you don't have to have access to the device that you showed.
And actually you can use the, I'm sorry, the name is slipping my mind right now, but the longer infusion, thank you, angiocath, to actually infuse the lidocaine. Yep.
So, and I'm here at Stanford, and we have a lot of peds residents that I work with, and then a lot of EM residents that do both children and adults. And this is becoming a sort of wildly burning in the adult side. Everybody is using it. Everybody is loving it. And so I decided, oh, well, I'm going to start using it in peds. And Dr. Haywood, as you said, I did not have anything fancy because I wasn't going to order anything, and this hasn't really been done before. So I just, old style, I went and I whipped out an angiocath out of the IV card, put a 1% lidocaine in it, put the kid's head back in hyperextension, and went in not very far at all. I marked it. I marked the nasal canal, and I basically was not going to go further than that. And I just put a couple of drops in each nostril. But I will tell you, Mo, just like you, I only would do that with people that had a history of chronic headaches, were on patches, were on maintenance medications, and they come to the ED with their eyes closed and vomiting and still not getting better. And I mean, I have not studied this, but I tell you, it works like a charm.
Yeah, it's
I'm sold.
pretty amazing.
So yeah, it's pretty amazing.
I think,
thank you so much. This was excellent.
Oh, thank you so much. I think just pointing out though, the kids that, are not the chronic kids, obviously, we all work them up either by history, physical, imaging, etc., for any other underlying pathology. But I don't think this should, you use your clinical judgment. If you feel like this kid just has a run-of-the-mill headache, I think this is perfectly fine. But obviously, if there's any indication for any other underlying pathology that needs to be addressed, obviously, this is not going to be what we should use in that case. Yeah.
Thank you.
Thank you guys for this opportunity. It's great talking with you.
Thanks, likewise. Okay. Hi. Think you're up next?
I think it might be me.
Hello.
All right, good afternoon. This is Jim Holmes. I'd like to present an abstract on does attention deficit hyperactivity disorder increase risk of minor blunt head trauma in children? I'd like to thank SAM for the opportunity to present. I'd like to also thank my co-investigators who are spread out across the United States. This study was funded by an R01 from NICHD for a larger project. There are no other disclosures. As we're all aware, attention deficit hyperactivity disorder, or ADHD, is common. The prevalence of ADHD in the US is estimated to be somewhere between 7 and 9.5%. We also recognize that injury is the leading cause of morbidity and mortality in childhood. And there's a variety of people that believe ADHD may increase risk of injury, especially injury to the head. Therefore, our objectives were to identify the prevalence of ADHD in children with minor blunt head trauma, and if ADHD increases the risk of that head trauma. We hypothesized that children with non-motor vehicle collision mechanisms of injury have higher rates of ADHD than children in motor vehicle collision mechanisms, and rates will vary by specific mechanisms of injury. And I'll explain why we separate by motor vehicle collision or non-motor vehicle collision in just a minute. This was a 6-site prospective observational study of children with minor blunt head trauma. The primary study was designed to validate the previously derived PECARN head trauma prediction rule, and this was a planned sub-study of that major project. We took children from 4 years of age up to 16 years of age with GCS scores of 14 and 15 following blunt head trauma. We chose 4 years of age as the start, as this is when ADHD is first beginning to be diagnosed in the population. And I'll explain why we chose 16 in just a second. Guardians were queried about prior diagnosis of ADHD in the patient, and then patients were categorized based on their mechanism of injury. Patients in motor vehicle collisions were considered to represent the prevalence of ADHD in the community. That is, we chose children from 4 up to 16 years as they would not be the driver, and therefore the diagnosis of ADHD should not impact a motor vehicle collision. Now, there could be a case of the ADHD being so bad that the driver was distracted with the child in the car because of ADHD behavior, but we thought that would be rare. We use simple descriptive statistics, and we compare those patients in motor vehicle collisions versus those in non-motor vehicle collisions for their rates of ADHD. We also did a multiple logistic regression model to determine if those with ADHD are at increased risk of cranial CT scans or traumatic brain injuries. We used a fixed effect model to adjust for differences between sites. We enrolled 4,000 children. 84% or 3,410 of those children enrolled had ADHD data available and therefore represent the study population. Those children who were enrolled but did not have ADHD data available were similar in age, mechanisms of injury, sex, and rate of CT scan as those that were enrolled with ADHD data, suggesting there was no bias in the sampling. The mean age of the enrolled population was 9 years, and 63% were male. The rate of ADHD in the enrolled population was 8%. When we compared the rate of ADHD and motor vehicle collisions, which we believed would represent the baseline rate of ADHD in the population, to those that were in non-MVC mechanisms of injury, we found the rate in the MVC population to be 6.5%, the rate in the non-MVC to be 8.3%. That difference was 1.8%, and the difference in rates crossed zero, so this was not statistically significant. However, when we compared the rate in the motor vehicle collision, which was 6.5%, with specific mechanisms, we noted that several mechanisms of injury had significantly higher rates of ADHD. That included assault, auto versus pedestrian, and bicycle injuries. And those difference in rates ranged from 7 to 15% more in those three mechanisms. However, falls, object strikes head, and motorized vehicles such as motorcycles or ATVs or go-karts, there was no difference in the rates. When we looked at the rate of cranial CT in the population, 43% of those with ADHD underwent cranial CT scanning, whereas 32% in those without ADHD underwent cranial CT scanning. And so we were concerned that there might be a difference here. However, when we performed a multivariable regression model, where we controlled for age, sex, PECARN head injury risk variables, there was no association identified between a diagnosis of ADHD and undergoing cranial CT scan with an odds ratio of 1.17 that crossed 1. There are certain limitations to this study. The reference group, that is those with motor vehicle collision mechanism of injuries, was used to estimate the baseline rates of ADHD in the population. Our baseline estimate was 6.5%, which is slightly below what the estimates are in the general population that range from 7 to 9%. We excluded those with severe to moderate head injury, that is those with GCS of 14, but that is a very minor number of patients in the population. And then patients were not formally tested for ADHD. There could be misclassification bias, as children may carry a diagnosis of ADHD when they actually do not have it, or they may have ADHD and not yet have that diagnosis. In conclusion, children reported to have ADHD with minor blunt head trauma are at increased risk of certain mechanisms of injury, including assaults, bicycle crashes, and auto versus pedestrian incidents. Future studies should evaluate interventions in children with ADHD to promote injury prevention efforts for certain mechanisms of injury. Thank you very much, and I'm happy to answer any questions.
Dr. Holmes, I thought that was an interesting talk, and it's not an association I was aware of previously at all, so I thought that was just a fascinating thing to learn about. I find it interesting that the different mechanisms, if you go back to your conclusion slide, I think you said it was auto versus pedestrian, bicycle, and then assault were the three that you showed the difference. It makes you wonder, I mean, those are, it makes, I wish if fall fell in those, then you'd think about, you know, if it's an executive functioning disorder, are you being distracted and getting injured? It just, the reason as to why I think is interesting for those specific mechanisms where you show a fairly substantial difference there.
Yeah, we can make sense for assault, auto versus pedestrian, and bicycles. Fall is kind of the main reason that we didn't see any difference when we kind of lumped everything together, simply because fall was such a high rate. We had 16 times the number of falls as we did assaults, for instance. And so that kind of washed out. And most of these falls are ground level falls. And so probably ADHD doesn't play that much of a role with ground level falls. However, you can certainly see how auto versus pedestrian and bicycle accidents, certainly ADHD would play a role there.
Right. Yeah, no, it's a fascinating association to show. Cool.
There's one other study that just came out. We kind of got scooped. We were a little depressed about that, that recently came out on this topic that showed similar findings.
So this is Mo. Sorry if you may have mentioned it and I just happened to miss. But assault category, would this be victim of assault, or is there also a look at who perpetrated an assault, trying to figure out whether this is aggressive behavior or just aggression towards that person?
This is any fighting. So if they were basically involved in a fight, they would be classified in the assault category. So they could have been on either side of what you described.
Okay, and the ADHD you mentioned, there wasn't any formal testing. So you looked at anybody who has in their history ADHD mentioned, or how do you actually classify the ADHD?
Yeah, we actually asked the guardians in the emergency department if their child had a prior diagnosis of ADHD. We also collected data on, and I apologize, I don't have the slide. We collected data on whether or not they were on medications, but that didn't seem to impact the findings at all, whether or not the guardian said they were also taking medications.
It'd be nice to correlate this ADHD with future emergency medicine as a job.
Any
They'll
final
for
questions?
sure find a correlation.
Yes, there's probably some truth to that. Thank you very much.
Thank you, Jim. That was awesome.
Thank you very much. All right, let's see. How are we doing with time? Are there any other questions at all? Do we have anything in the chat? No.
No questions in the chat.
All right, you guys, let's see. How are we doing with time with our session?
We are actually early.
Yeah, we have we have till 50 minutes after the hour, so we have 16 minutes left.
Yeah, I don't see, I'm not sure if other people are going to be logging in.
I think that was the last, mine was the last abstract. I think we must have had an abstract pulled simply because there was a 12-minute gap in the times for the abstracts.
Yes,
earlier,
I noticed that. I agree. So I'm happy to stay if you guys wanted to as well, but I don't think that we're going to have people joining us without hearing the presentation. So I'll mute myself if there's anything else needed. It was really nice to see all of you, and thank you for your hard work and dedication and your presence here. I appreciate it. Thank you. Have a good afternoon.
Thank you very much.
Thank you guys. It was
Thank
great
you.
to do this.
Thanks, everyone.
Bye, guys.